to reduce its toxicity by adding NAC in your formula.
Oh.
Name it. Antibiotics, you're taking aspirin, you're taking paracetamol, you're taking amloxanox, you're taking psychology reported up to now. You're taking the other drug that we talked about, Dr. Joseph. We talked about the drug, methyl, I think it's called methyl, the fumaric acid. That one. Also, you can detoxicate it by using NAC. So NAC, to prescribe NAC 500 to 1 gram daily for anybody, especially the long-term prescription.
Yeah.
And if what do you think, Dr. Joseph? What's the name of the drug?
It's dimethyl fumarate. Dimethyl fumarate.
Yeah, it's methyl fumaric. What is it?
It's a what? Sorry.
The name of the drug that you talked about there last week.
Yes.
Is that the methyl fumaric?
Yeah, dimethyl fumarate.
Dimethyl fumaric. Yes, dimethyl fumaric. That drug, if add NAC 1 gram a day, I think you can minimize any use of it in liver and the blood and the bone marrow.
We haven't had any issues with it. But then again, me and Dr. Dell, we're taking the amlexanox and KPV though as well, and I think you're taking the NAC.
Yes.
Already anyway. So, it had minimal, barely any issues, like none. Like it's like maybe a little bloating for whatever, but that like one time and that's it. That dimethyl fumarate has very quickly become the number one. Everything has its place, but dimethyl fumarate, I've never had anything do what it's done. And like I said, my symptoms were the kind of impossible symptoms that it seems like nothing can help, especially when it's neurologic. But I haven't had any headaches. The chronic neck ache is, I haven't had it for 4 days now since I started taking it. It works immediately. I'm not exaggerating by any means. But I think when you nail the mechanisms down, that's when the magic happens. But I think you need the amlexanox, the KPV, and the dimethyl fumarate. That's like it's like a steroid without the side effects.
That's fantastic.
To ensure that there will be no side effects, according to the publications, they're adding NAC to it. So I can show you and share with you articles that helps to detoxify any of those, because fumaric turns into succinate, so that's biologically friendly. But the methan dimethyl can turn into methanol that can be a little bit toxic if you take it for 8 years straight. But you can detox that using NAC. So as long as you're taking NAC, you're on a good side, right? And I think amloxanox, because it helps to restore the genetics, the nonsense mutation, then now we have a solution for all nonsense mutation genetic diseases, which is 1/3 of genetic disease. There are nonsense genetic diseases, including cystic fibrosis. So think about it. Now you have a solution to restore the missing protein, which is the protein that makes the chloride and making the sweat less salty, right, and more fluidy, and all the mucus will become more fluidy with amloxanox. And then you add the NAC to it, you can treat and reverse the root cause of the pathology of fibrosis, genetic diseases, and you can clear the symptomatic as well. So with two combination of amloxanox with the NAC. So yeah, I think we are.
I do want to mention
getting into something.
Yeah, I want to mention one thing though. I read an article from 2013, a publication on HIV and dimethyl fumarate, and what I learned, the reason why I went through it, it's a very long article, is that I'm starting to see that there's actually a lot of similarities between HIV and COVID, and for the people who have like the chronic symptoms, chronic fatigue symptoms that never seem to go away, it really looks like HIV. And one of the things I learned is that it's like you have a chronic activation of your monocytes, the microglia. They are constantly releasing cytokines. But one of the things I realized, or at least in this article talked about, is that in the brain, a part of the issue is that the microglia and the monocytes are and macrophages are overexpressed, releasing neurotoxins, in particular like glutamate. So you get to sort of like this chronic excitation, neuronal excitation, and I think that has a lot to do with the neuroinflammation, the overactive sympathetic nervous system, the neck pressure and pain, which this is not just me. I hear this from most of the people who have chronic symptoms, but it's also showing that dimethyl fumarate suppresses that, blocks that, modulates it. And so it's just another piece of the puzzle to explain things, or at least that's the way I did it, is to use that model as a possible way to see what could be happening, and then how does dimethyl fumarate play into it, because all of these things have their own their role. Dimethyl fumarate is like stacking. If you stack things together, it's like the third line treatment. If the amlexinox and the KPV are not enough, then you can move to the dimethyl, or add the dimethyl fumarate.
Good stuff. All right. Well, without further ado, I'm going to start my lecture here. Oops. How do I go back? Okay. So my name is Stefan Hartman, PA, owner of Iron Direct Primary Care. Today I'm going to be talking about what to do for the congested patient, specifically NAC for nebulization, for mucolysis. So why this topic? Well, we got a big problem. People will come to you congested, mucus. Hey, can I get an antibiotic for this mucousy cough? No, we know that's not the answer, but people still suffer with mucus congestion. They can't breathe. They got phlegm. What do you do for them? Well, you send them to Walgreens. You get them a pseudoephedrine or the Mucinex junk. It doesn't work. Some of them are dangerous than others. They can increase blood pressure because they're vasoconstrictors. Tessalon pearls, they're cough suppressants, but they don't work that well for everyone. So we need a better solution for this. N-acetylcysteine is an old and known medication. We know it's a natural amino acids in the body. Cysteine and glycine, they're the building blocks of glutathione, which is the body's master antioxidant. So we know that this is an antioxidant. We need it in the body when we're in a disease state. We need more of this antioxidant. So we have studies to support the use of nebulized, so specifically breathing in the mist of N-acetylcysteine. This study, I like this one because it describes some of the mechanism as why you would want to use this. The glutathione stands for GSH. It acts on several enzymatic systems in the body that, let me let these people in, that help eliminate free radicals and detoxify fat-soluble components. It also exerts a metabolic role in various biochemical processes, including amino acid transport, DNA synthesis, and immune system improvement. Now, this is important. In the epithelial lining fluid of the lower respiratory tract, glutathione is the first line of defense against oxidative stress, and the concentrations in the lung are 140 times higher than in the serum. And alterations in glutathione metabolism in the lung are considered central in the context of inflammatory lung disease. So that was quite striking when I was learning about N-acetylcysteine and glutathione, is that we need it more in the lung. So NAC has demonstrated as we were talking about, Dr. Klatz and I talked about earlier, as a mucolytic, right? He was using this a long time ago as a respiratory therapist for cystic fibrosis, mucus disease, mucus plugging disease, and NAC nebulization was very effective for bringing this up. And although acknowledged in several societies, there has been little momentum to apply this drug for the primary care patient or the urgent care patient with congestion issues. So maybe some of the hesitation, if you talk to someone about nebulizing N-acetylcysteine, they'll say, oh, that's dangerous. You're going to give the asthmatic a bronchospasm. They can end up in some trouble. Well, you just make sure your asthmatic has a little bit of albuterol or racemic epinephrine that they can add into their nebulizer, and they can breathe in both at the same time, and you negate the problem of the bronchospasm. The asthmatic lung, as we know, it's also a lot of inflamed and excess mucus. So the asthmatic patient is exactly the type of patient you would want to use an N-acetylcysteine in, and not someone you would find maybe a contraindication to using it. So let's talk about NAC, nebulization of glutathione and N-acetylcysteine as a therapy in COVID-19 onset. We know that the COVID-19 is a high oxidative stress. And where does this oxidative damage happen? It happens in the lung. Let's see. In the acute phase of SARS-CoV infection, there is erosion of the epithelial lungs that line the airways and accumulation of debris and particles that obstruct the regular breathing pattern. This exacerbated inflammatory stress from an infection can stimulate excess of secretions in the lung, including fibrin, compounds, proteinaceous materials, impeding the essential gas exchange for the maintenance of vital organs. Okay, so that's a problem. We don't like that. So we use glutathione or N-acetylcysteine nebulizations to help remove these debris, improve oxygenation, buffer oxidative stress. This study here, treatment of pulmonary diseases and respiratory-related conditions with inhaled, so that's nebulized glutathione. Unfortunately, I haven't found an actual legitimate source of nebulized glutathione. Maybe this is only for research purposes. We're going to talk about more practical procurements of these medicines later. But a lot of studies we're going to talk about here describe glutathione nebulization. Some side effects of this with specifically NAC, the children I prescribe this to will tell me it smells like eggs, and they make a face at it, but they can tolerate it if you tell them they need to do it. Oxidative stress in chronic obstructive pulmonary disease. NAC, again, widely investigated drug with antioxidant capacities. Although given initially because of its mucolytic properties, NAC is a thiol-containing compound that may act as an antioxidant by providing cysteine intracellularly to enhance the production of glutathione. So I think this is also a practical way of delivering glutathione to the body. Some patients not able to tolerate NAC orally, they'll tell you that it makes them puke, it makes them stomach upset. So nebulization is another easy route to deliver it into the body, when you don't have other opportunities like IV access. NAC decreases hydrogen peroxide-induced damage to the epithelial cells in vitro and NF-kappa B activation in some cells. In addition, NAC treatment reduced cigarette smoking-induced abnormalities in vitro. The clinical efficacy of NAC has been investigated in a number of trials in patients with chronic bronchitis with and without COPD. Treatment with NAC caused symptomatic improvement in COPD patients reflected by decreased sputum viscosity and purulence and improved sputum expectoration. In addition, NAC treatment reduced the number of exacerbations and sick leave days in some patients. NAC treatment also decreased the number of viral infections and airway bacterial colonization. Right, you get a patient with COPD into the urgent care, what do? Azithromycin, doxycycline, right? Every time, because we know those things, they help with the inflammation in COPD. Whether it actually treats a bacterial infection for COPD, we don't really care. We just use those antibiotics as kind of like cover your ass, get them a medicine. The patient feels they treated, you feel that you treated yourself, and they can leave all happy. But we have here N-acetylcysteine, less harmful, and potentially can also help your patient feel better, and everyone leaves happy. We're going to talk about some IV studies as well, just to kind of compare and contrast the different forms of NAC. This one was kind of an interesting study because they showed that IV N-acetylcysteine, it actually didn't improve survival in these children with acute liver failure. I thought that was kind of interesting. But the reason for that potentially can be because the response to the acute liver injury, you may need some oxidative stress in pediatrics. There's some theory as to why you wouldn't want to give them a bunch of antioxidants. So there's some, we won't get into details there. This study, viral acute fulminant hepatitis, they studied this, and again, in children, N-acetylcysteine using pretty high doses of NAC IV. NAC is used in developing countries where they don't have access to liver transplantations. We skipped the page here. It jumps around here. So it's used in developing countries a lot where they don't have access to liver transplantation. So you'll see some studies of safety and applications for these in the Middle East and such places. Here's a case of children with a dengue fever and liver failure, a case report. They use NAC. The patient did improve. Again, where liver failure. Let's see. Let's skip some of these here. Not so interested in the IV application. Maybe someone else can talk to you about that at another time. So what's the rates of adverse events with intravenous versus oral N-acetylcysteine? Puking. That's my main point, is when you give it orally, and I've done this many times for patients, it makes their stomach upset. So again, some more N-acetylcysteine studies here showing that not much happened in this study, but at least it didn't harm. This is one in non-acetaminophen acute liver failure. NAC is a safe for non-acute acute liver failure. It can prolong patient survival with native liver without transplantation survivor after transplantation, but it cannot improve the overall survivor. That seems to be a theme we're seeing here. Let's get back to N-acetylcysteine for applications for respiratory diseases. So NAC was started use in the 60s for mucolysis, 600 milligrams a day as a mucolytic. That seems pretty standard dosing. You can get that in most pharmacies. In hospital settings, they'll do up to 150 milligrams per kilogram. So this is quite high doses, but as we saw in the previous studies, no harmful effects even in pediatrics with fulminant hepatic disease. Acetylcysteine, again, makes bronchial mucus less viscous. Let's move on here. So this is a study looking with acetylcysteine with salbutamol nebulization in acute bronchiolitis. Why would you want to do this? N-acetylcysteine cleaves disulfide bonds. This is for you guys who like to go into the mechanism. By converting them to two sulfuryl groups, this action results in the breakup of mucoproteins in the lung mucus, reducing chain length and thinning mucus. Mucolytics, like NAC, have been studied in the treatment of CF, bronchitis, idiopathic pulmonary fibrosis, and critically ill states. And I'm currently testing this out in a patient with idiopathic pulmonary disease, so we'll see how that goes. Effectiveness of NAC in children with acute bronchiolitis. So they had 16% reduction in the mean length of hospital stay among infants hospitalized with viral bronchiolitis. This percentage reduction in hospital stay is low compared with other studies where hypertonic saline was used. We're going to get into hypertonic saline in a little bit. Effectiveness of nebulized NAC, again, in children with bronchiolitis. So they were assigned to one of two groups. One group got 20 milligrams NAC in 3 mLs So that's pretty standard. You can find that on McKesson, that formulation. Group 2 received inhalation 2.5 salbutamol in 3 mLs with saline. Patients in each group received 3 treatments every day, delivered at intervals of 8 hours for 5 days. 100 children were enrolled. Oops. Back up here. Let's see. So group, let's see, total 50. Group 1, less than 5 days, 31. So group 1 was in the hospital less than 5 days, 31 patients. Group 2, 23, greater than 5 days, 19 total. I wouldn't say there's too much difference between those two. This one looked at combining 10% acetylcysteine and 3% sodium chloride in a nebulizer therapy for acute bronchiolitis in infants. 82 patients with acute bronchiolitis have been examined in the control group, the first 21 patients who received traditional therapy, and group 2, 21 patients received acetylcysteine. In the fourth group, as patients were examined on a reliable improvement of cough, sputum indexes, and saturation scale, duration of hospitalization, oxygenation, not only in comparison with the control group, but also in comparison with groups 2 through 4. Combined nebulizer therapy with use of 10% acetylcysteine and 3% solution of sodium chloride can be recommended for the treatment of children with acute bronchiolitis. Oops, let's go to the next page. Yeah, okay. Rational use of mucoactive medications to treat pediatric airway disease. So mucokinetic medications like NAC, mucokinetic medications are intended to improve the effectiveness of ciliary propulsion or cough. Although beta agonists such as salbutamol increase ciliary beat frequency, there is little evidence that they are effective mucokinetic drugs. Mucolytics, this would be an acetylcysteine. They break down mucins at the cross-linked disulfide bonds across adjacent cysteine residues. These classic mucolytics, such as NAC, is the archetype, and they contain the free thiol groups that are used to hydrolyze these disulfide bonds. Let's see. So they talked previously about saline, and I used to prescribe saline extensively, like 3%, 7% if I could get it. The saltier, the better. But I found that NAC, it works more effectively than the saline. And if you look at some of the studies, the saline is supposedly, it can make some secretions worse. So I've gone away from using sodium chloride, hypertonic sodium chloride so much, and I'm using more NAC now. But I'd say the sodium chloride is still more commonly available at pharmacies. You can't get N-acetylcysteine very easily. So these are some case reports. Because I've been using this quite extensively. So this is a 4-year-old child who's been sick for 3 weeks with a fever and cough. We used it on them. No bronchospasm occurred. I saw her in the office. Her lungs were clear and she appeared well, other than the cough and the mucus dripping. And I followed up the next day after I gave them the NAC, and they said that they did it. The fever finally broke. They used it on another child who was in the family sick with the same thing, but the child improved much quicker than this other one who waited so long. Let's see, a 29-year-old female. She says she had a month-long sinus infection, pressure in her head and ears. And she said the NAC was the only thing that gave her relief after a couple of days of using it, and it helped her get over the problem completely. So she will use it pretty regularly. She picked it up for me the other day because she wanted to have it on hand because it was so successful. This is a 35-year-old female with COVID positive, and she said, I could tell it started making me cough up more, so that's good. I did have a slight burning sensation in my nose as I inhale in the nebulizer, and some same slight burning sensation in my eyes. But since she tolerated it well, I saw her today, and she was fantastic. She recovered from COVID very quickly, even though she had the Delta variant and was almost hospitalized for it the first time around. So she's a heavier set lady, and she had some real problems with COVID, but she made it through this time okay. 2 children, ages 8 to 12. I used it on the 12-year-old when he was sick. but not for asthma, just to clear the mucus from his cough. And mom reports, I'm now using it on Vera, who has a yucky cough. I have 2 doses less. She nebulizes every morning and it's making a difference. If she sounds yucky before bed, we have her do it again. She hates the smell, but she only coughed up yellow for 1 day. I believe that's thanks to the neck. So practical tips for this is to own a nebulizer, as I don't know what's going on with the pharmacies, but you can't find a nebulizer anymore. I don't know if any of you have tried to prescribe a nebulizer. Give it a go. You'll find that no Walgreens, Walmart, Costco, they don't have nebulizers anymore. I remember in the pandemic, I could still prescribe them, but now you can't get them for some powers that be decided that was the right thing to do. You can still get it at Amex pharmacy, and that's probably the only.
Amazon has it.
Yeah, that's what I'm showing here. You can get these
Amex.
ones
Yeah,
from
Amex has it.
Yeah. So that you need to tell your patients to be prepared to have the nebulizer in their house, but then they also need to have neck in their house as well. And it needs to be sealed, because once you open it and puncture it, according to pharmacists, it expires very quickly. So like you have to use it up within a week before it starts. I guess maybe Mike Boehmer can explain this better to me, but it's apparently not as effective. So I will order these, keep them in my office, and dispense them to patients when they're sick with the mucus.
Yeah,
problem.
refrigerate the Mucomister, the NAC, and it'll last a lot longer.
Yes. How long do you think it could last?
You know, my experience, unfortunately, is 40 years old. Back when we used to routinely keep it for maybe 5 days a week. You can tell when it goes bad because it loses its smell.
Right. Eggs. You want that eggy smell.
Yes. So reseal the bottle. It comes usually with a rubber stopper. At least it used to come with a rubber stopper. I don't know what it does today.
And there's still a rubber stopper. You just plunge or you pull out the fluid and you push it into the nebulizer.
Okay, well, you may want to take some saran wrap and wrap it over the top of it to maintain an airtight seal, and then keep it in the refrigerator. You should be good for probably a week.
I love that. That's great.
Hey, quick question. Stefan, what's the concentration again? Because I've ordered NPC quite a bit from the compounding pharmacies, and I know it's too strong by itself, most likely.
So you can prescribe it at Walgreens. You prescribe it 20 milligrams per ml. It's a commercially available product, and it comes in a 30 ml vial. And so you write it to the Walgreens. You say use 3 ml via nebulizer, 3 times a day for mucolysis, 30 ml vial, and they can order it special and get it in typically within about a week.
Oh, so that's already a pre-mixed bottle. But what about from the compounding pharmacies when we get it pure?
No, compounding pharmacies don't carry it. I asked extensively. They don't carry it.
Well, that doesn't mean that we cannot dilute it, though, in normal saline. I don't think.
I don't think so. And it needs to be special grade for nebulization.
I can help. If you dilute it, Dr. Joseph, the key is if you keep it sterile. There's 2 issues: sterility, and stability. Right, 2 issues. So Dr. Klatz kind of spoke to one, and I would agree. If you open something, close it back up, and put it in the fridge real quick, keep it in a very germ-free environment, a cool temperature. It's good. You got a little bit of time with it, especially you're not introducing it into the vein. You know what I mean? It's still nebulized, and you're still breathing in air. So sterility is important, but it's not as important probably as if you were injecting it. Now on that side, on the other side though, you could dilute it with something sterile. The issue I think that Stefan's bringing up, Dr. Joseph, is he's giving these to patients to take home, so it's got to be something they can do themselves. You know what I mean? And so if they have to dilute it, it maybe makes it a little bit harder for them. But you could dilute it. I mean, it's just another step, and the patient can't do it.
Yeah.
Well, and I guess that would be the context of me doing it with the patient, or for myself. You know what I mean?
Surely you can do it. Yeah, absolutely. Yeah, you can.
Yeah, but I was just saying we don't know what the dilution would be.
It's 200 milligrams per ml solution in a 30 ml vial.
Mike, as a pharmacist, Mike, as
Yeah,
a
so
pharmacist.
1 ml in your neb cup is 200 milligrams, guys. You put 1 ml in it. Is that what you do, Stefan? 1 ml?
There's a dead space in the nebulizer, so you're gonna miss that 1 ml. You need to put at least 3 mls for practical nebulization.
Oh, yeah,
No,
you got
no,
well,
but
you got to add
I
saline.
think you would dilute it. But I'm thinking you would dilute it though. If you put 1 milliliter, you would dilute it in 4 milliliters of normal saline. Then
Correct. You can do that. You can do that, guys. I mean, I'm not saying anybody's way of doing it wrong, but you can buy sterile saline for that purpose to dilute it with. In other words, a typical nebulizer, oftentimes patients do add sterile saline. They make little vials of sterile saline.
Yeah.
They're just like the nebulizer vials for albuterol. They look just like an albuterol, but there's just saline in there. And so often, I think they each have 2 cc's. And typically a nebulizer, what they would do is if they wanted to dilute it, they would use those. So that, like a pulmonologist, they would use those for diluting a neb solution if they didn't like the concentration of what it was. That's how they used to do like the half strength albuterol, for example. So either way is fine. It doesn't matter, whatever person prefers, but you could dilute it if you wanted it to.
Mike, as a pharmacist, do you have any solution for making the smell go away?
Well, I'm going to quote Dr. Klatz on that. When the smell goes away, so does the effectiveness.
Yeah.
It's unfortunate. Yeah.
But if you add something just to flavor it, to make this, instead of smelling the egg, you smell something else, or something to mask it, not to change the property. I mean,
yeah, cherry flavored poop still tastes like cherry flavored poop.
Yeah. They sure do.
like this,
Yeah.
be that.
Yeah, that's what I would think.
Stefan, I think
Yeah, I was
one
just
thing that's important is the dosage.
The
Like,
horse.
Yeah.
what dosage do you like for each nebulizer treatment? Is it 200 or is it 600?
600.
Okay,
Yes, there's
that's the
different-
key.
different-
Yeah.
You guys are giving different amounts,
Oh, yeah.
Dr. Joseph. Yeah, so he's giving a much higher dose. Yeah, that's what it is.
Yeah.
Like 600 milligrams.
Yeah.
Mm-hmm.
Okay, see, because so I think it sounds like we don't know if we're making it ourselves because we don't know if it's going to be too irritating because it could be too acidic. If we were to do 3 cc's of the 200 milligrams per milliliter and only dilute it with 2 milliliters of normal saline, I think we would be kind of guessing.
I like that idea because there's been some patients, I mean, they can all tolerate it. It's just because they complain of the egg smell. Diluting it down probably would decrease the concentration of the egg smell.
Mm-hmm.
Well, the egg smell isn't the issue that I'm talking about. The issue I'm concerned about is if it's too acidic and you're inflamed, the patient is inflamed, it's going to exacerbate the symptoms that they're having potentially, because that's something just like with peroxide. There's a specific dilution. Otherwise, you're going to trigger too much oxidative stress.
Uh-huh. Maybe that's why
Instead
the
of-
recommendations are often to mix it with albuterol to avoid the bronchospasm.
well, there
no,
is
no, you
something. There's something out there that I know that helps to take off the smell of anything. It's called misk. It's from Middle Eastern, especially Saudi Arabia and the desert, and they extract it from the deer. It has a very nice smell. They put it in a perfume, but it's very strong. It will mask any smell that's something different. So just have the patient put 2 drops in their nose. I think this will help to take the smell out, because I can see the disgust of it.
Yeah.
It's called mist.
That's interesting.
Have you heard about mist?
No, I haven't, but I can tell you what you could do is even an essential oil of any sort. If it was a child or something, and you put a little essential oil under the nostrils or something like that, that whole
because
idea
mist
might
is
work
essential oil as well. It's an oil, and it's not irritant, and you can put it on their nose, and I think that may help to get rid from that smell. That's just my suggestion. So I want to see if Stefan will start applying it and then let us know, because this will be something that helps to make people interested more in it, because I think NAC, it's something that we are missing in our regimens and protocols.
I think you're referring to musk. MUSK.
Yes, in Arabic it's musk, and English is musk. MUSK. Yes.
Yeah, musk is an odorant, and you're right. It will confuse the olfactory, but so will any essential oil. So you could use like lemon or orange or even peppermint, and you put a dab of peppermint under the nose, you're not going to smell anything.
Mhm.
Yeah, it just overpowers the olfactory bulb.
Makes sense to me. I wouldn't put it in the neb cup though. Don't put it in the neb
No,
cup.
Neb cup. That wouldn't work.
Okay.
And I think you can dilute. I used to. Now again, my experience is 40 years old, but when I was in respiratory care, we used to dilute it. We used to dilute that with saline all the time, and we still had good results. So things may have changed.
Nah, I think you're right. I think it's not with that one. It's an old drug.
Yeah.
Yeah, all
I think it
drugs.
depends on the dose you want to give and what your patient can tolerate. You know, a guy that smokes 3 packs of cigarettes a day probably isn't going to complain. They can inhale anything and it'll stay down. But a child may really have a different problem. You know.
Yeah, for the most part, I mean, if you breathe this stuff in, it's very mild.
Yeah.
You don't really notice it.
I like the systemic effect that you're going for there. I think that's something I haven't heard before, you know, like to consider that as a, you know, as quote unquote, a pseudo intravenous treatment, you know. Yeah.
I mean, your lungs are big sponges, but particularly in the case of NAC, it's 140 times more concentrated in the lungs
Mhm.
than the serum. It's the obvious roots.
Mm-hmm.
Do we have any questions, comments?
Now we'll let you get back to it.
Yeah.
Mm.
Let's see, how much does... Can you lose it?
So I did have a question going back to the earlier slides.
Yeah.
When they were treating some of the viral hepatitis.
Yeah.
Now, is the purpose just to reduce the oxidative stress in the liver, or is there another sort of reason?
It looks like it didn't work. Like all the studies with IV N-acetylcysteine for hepatitis, it doesn't seem to matter too much. Yeah.
So it didn't make much of a difference. So it worked.
No.
So the point is, seems to work best in the lungs for more acute situations. Is that the point?
It seems to work better for lung disease rather than trying to use it specifically for like hepatitis or dengue or idiopathic, whatever it may be. I mean, it's a good idea, but it doesn't seem to change much.
I have a comment for you guys here. What's if you look at the last presentation I did on losartan, it was one of the drugs we covered, and if you look real carefully at losartan, interleukin 1 or beta 1 is the driver of fibrosis, whether it's in lung tissue or in liver tissue. There's a different mechanism in each case, but what you're addressing with NAC is the oxidative stress and inflammatory component. But in the end, interleukin 1 beta is secreted and it stimulates the fibroblasts. They're a certain kind of fibroblasts, and and that's what causes these fibrotic eye and lung and liver conditions and even kidney conditions. So what it is, you got one piece of that therapy. But if you know, like for example, you could use any, you know, whether you use vitamin C or NAC, or you use glutathione, or you use methylene blue, or any of these things are all good. But at the end of the day, if you don't kill off that interleukin 1 or beta 1, then you're still stimulating the fibroblasts. So you're helping to downregulate them. But it's losartan is a good combination with that kind of thing if you're dealing with fibrotic disease.
Yeah, I was gonna say, it seems like to me then the NAC, when it's given in nebulizer form, the immediate effect maybe, because it's also called mucomist, so it's increasing the secretions, and I would think that that's the more immediate effect versus the antioxidant effect, which would be a more later effect if it's helping with the production of glutathione. But my question is, how quickly does the glutathione get produced after the NAC that would allow the buffering of the redox? You see what I mean?
I see that.
So let me comment on that if I can. What's going on, guys, there? It's a good question, Dr. Joseph. What it is, there's two separate effects. There's glutathione is made out of NAC, that's true. But the effect of NAC as a mucolytic is an intrinsic property of NAC. It's not dependent on it making glutathione. So when you use when you are using it in a bunch of mucus, you're not. And oh, by the way, it doesn't increase the secretions themselves. It makes them more liquidy so that you cough it out. There's a more purulent cough, but you're not getting more. You know what I'm saying? So the key though is that when the mucolytic effect burns up the NAC, it's not available for use later. It's gone. It's like ruined.
Okay, so that makes sense. Yeah, it's loosening up the secretion. That makes a lot more sense. That's
It's
really
specifically this. If you're looking
not
at
necessarily buffering the redox.
No.
It could if there's excess. If it's not all used up in the process of mucolysis, then it would be remaining there for redox or for detox or glutathione production. So it's a matter of dosage there.
Okay.
Yeah,
there's a super high dose would hurt, you know. Yeah.
There's that.
So anyway, I'll let Stefan continue. I just want to wait.
Specific mechanism that you're looking for is this thiol that breaks the mucus. Yeah, this is what you're looking for in the neck. So it's specifically helpful for the mucus problem that these people complain about.
Okay.
Yeah, whether it produces glutathione, I think it can. I think it can improve it can buffer the redox.
Yeah, but that may be a downstream effect. You know what I mean? That's when I'm trying to make sense of things. You know, the more I think about, like, even that situation with the hepatitis, and you said it wasn't the studies were showing it wasn't really making a difference. Well, it sounds like to me like maybe perhaps that was in the acute setting. Not so much, you know, more of a long-term effect of trying to increase glutathione levels. So in the moment, maybe there wasn't much difference, and that was why it wasn't affected.
It was interesting that this actually showed a worsening of survival with NAC IV for these children with acute liver failure at 1 year. Why this happens, there was a lot of theories as to why this was happening. I don't think there was actually a clear consensus on that. The hypothesis is that the immune or inflammatory dysregulation drives liver injury for many in the indeterminate cohort, although little is known of the ontogeny of intrahepatic immune responses. Evidence suggests systemic inflammatory responses to trauma differ significantly between adults and children. So maybe it could work better in adult population.
You know, and probably
well, it's given for paracetamol toxicity to protect the liver from paracetamol-induced liver.
Paracetamol is different, is because the paracetamol burns through the glutathione.
Right. So it's a form of replenishing the antioxidants of the glutathiones and neutralizing the free radicals generated from the paracetamol, which is the quinins. I think the quinins are the byproducts of paracetamols. But I think it works for, I mean, all kind of chronic diseases. It will definitely help. Like Parkinson, we have problem with it because of the dopamine metabolized into quinins as well. So adding a NAC for the patient with Parkinson would help as well. And again, I think it's better if we add glycine to it, so we make sure we cover the whole other two components of glutathione, and we can help to detox the glutamate, the monosodium glutamate, which is one of the toxins in our food. You know, when we eat all those junky food, we feel like excited, another word, tired and exhausted, and it's because of the glutamate. And there's even also the pain, pain because of the monosodium glutamate that's in the food as a preservative or something additive. But
Yep.
that itself can be detoxified by NAC and glycine. So NAC is good all the way. I don't, but giving IV maybe was too much for the kids.
Maybe.
I don't think. I think the dose needs to be matched, or we need to figure out why exactly what happened, because I know for the fact that it's good for the liver in general, but
Yeah.
why acute liver? We need to investigate. Maybe the dose it's high or toxic. I don't know. But
Well,
that's just
my
my question.
My question is, in the acute settings like that, where you're requiring intravenous treatment, why not do a combination of glutathione and NAC? So you have glutathione's like the fast acting that's sort of detoxing and buffering the redox in the right away, where NAC is then, along with glycine, is helping to eliminate the excess glutamate. Is that the proper way?
I would love to get glutathione. I can't find it, but I always put it through the IV NAC and glutathione. I'll do both.
Why can't
Okay.
you use the IV glutathione for the nebulizer?
I don't think you can. It's an idea. I've never tried it. Never looked into
Well,
that.
I have
I
tried
would-
it myself during the
works?
time. I gave them an IV and I gave them also the by nebulizer, and it worked great. And there was not much coughing during that. So I mean, you know, if you have glutathione in your office, use that, and don't. If you have NSC in the office, you can use that. But if you don't have it, you can use the glutathione. We have worked in asthmatics. We have worked with COVID. We have worked with a lot of different type of conditions.
Fantastic. Yeah, makes sense. Sterile.
Well, it makes me wonder, though, in that context, Dr. Patel, maybe they didn't have a lot of mucus that needed to be broken up. Maybe they were just
No.
getting the benefits of the
You're right.
moisture.
You're right. I'm not saying no, but even for that, you can give the saline along with the following the glutathione, before the glutathione. If you don't have NSC, you can use that. But in early phase of COVID, they have dry cough. They don't have a productive cough. And during that time, if you can calm down the inflammation and use as a glutathione as a detoxifier and as a also anti-inflammatory agent, you can use it if you don't have an NSC.
Okay, that makes sense. Thank you.
Yeah, I love it. I'd love to use both. That makes perfect sense.
Hey guys, just be sure if you do that, you can mix them. I wouldn't probably put them in the same bag together. I'm not sure they're compatible. I don't know that, but I'd just be cautious to find out that they don't interact with each other.
What do you mean by that?
Well, they're both redox
No, you mean
chemicals.
IV? You are talking about IV?
Yes.
The NSC and glutathione?
Yeah, that's what I'm
You
wondering.
don't need both. You can use either or, because IV glutathione works so great. So why would you give NSC?
Good point. Okay, I got you. Yeah, that makes sense. I just wondered if they were compatible
Oh
in
no,
the
no,
same
no.
bag, or if they would react
I think wait a minute. IV glutathione, if you give it and continuously, it will lose its effect. And the reason it actually rebound and become toxic to the body is because of too much of glutamate that's being released from the metabolism of glutathiones. And that's why patients at the beginning, they feel good. And then when you give them glutathione, they say they feel awful. And the reason, because they have too much of glutamate as a byproduct of glutathione. And that's the reason we need to give NAC and possibly glycine together. And I will recommend Dr. Mike Boehmer to put the capsule 500 milligram of glycine and 500 milligram of NAC, so that we have a complete detox for glutamate, and will be something that we can use for everybody here. I think
I'll
it's
take
a
it
good
every
thing
day.
at night. It will calm people down. Glycine, it's like a very hypnotic, and at night it gives you deep sleep, and it helps to recycle the glutamate, the toxic glutamate that we have because of our food and environment, all that. We have too much of glutamate, by the way. We are toxic with glutamate. That's our food is full of glutamate. If you see the ingredients, you will see glutamate part of it, glutamate monosodium. It just, we need
You're
to
not supposed to
intoxicate.
eat box goods and outside goods, so you look at what you eat, you won't have a problem.
That's true.
Well,
I mean,
remember,
you're right.
well,
You're
remember-
right about taking orally when you're giving that, but there are patients those who will not be able to tolerate. So you have to again personalize whether they would take that medicine or not.
That's a good point. Doesn't work if you don't take it.
Yeah, and again, the other thing I mentioned earlier is that, or at least this was in the article with HIV infection, that it was causing the microglia, the monocytes and macrophages to release glutamate into the central nervous system, literally. So, it makes me wonder if other viruses have that effect. And so the glutamate, what if it's also being overproduced and released by our immune system, and that's leading to symptoms, and that just avoiding glutamate may not be enough, that we actually have to have the NAC in addition, especially if in chronic viral syndromes, in order to buffer that.
Makes sense. And if glutamate makes you tired and you have excess glutamate, and then the pathogen is stimulating glutamate production, that might be what's making you tired when you're sick, or contributing to it, right?
Yeah, I mean,
Do you know the pain
think about
signals of the brain? The brain, it's glutamate. The glutamate is it's the neurotransmitters of the pain signaling of the brain, the neuropathy, the nociceptive neurons, they release glutamate. So it is the neurotransmitter of the pain. And so think about it, adding definitely NAC and glycine in your regimen will definitely help to relieve even the pain that you have. And so too much of glutamate or glutathione, it can cause a reverse effect because of the release of the glutamate. I learned this from Dr. Cheryl. She's not tending anymore, but she's the one who told me about not to give glutathione all the time or continuously giving it. It can reverse effect because of the toxic of the glutamate, because it's a neurotoxic molecule in the brain, and it can cause all the degeneration and oxidative stress in the brain. So it's part of the treatment.
Dr. Halasa, but ALS patients, they improve a great deal when you give them IV glutathione. So I think one has to use the judgment that when and what dose they are going to use. But if you give between 2 to 4 grams of glutathione, it's not too much. And I'm talking about as a clinically and as a physician who have used a lot of it. You're right that patients should be on oral NSC and some other scavengers, free radical scavengers. So you can use that in a combination, but one thing is good, another thing is not good. It just doesn't work that way.
You're right, Dr. Patel. It depends on the pathology of the patient, because one person needs a lot more glutathione, has more demand for it than the next, maybe, yeah.
Well,
Dr. Patel? Dr. Patel?
Yes.
Hi, Dr. Klatz here. I thought I heard you a couple of weeks ago talk about a protocol for reducing visceral fat with periumbilical injections of oxytocin. Was I hearing things, or does that work?
I don't think I mentioned about that. I mean, I use a lot of oxytocin nasal spray, but
this was a subcutaneous injection.
Injections too.
Maybe I was mistaken.
No,
Yeah,
Dr.
that's
Halasa
me.
mentioned that.
Yeah,
Dr.
that's
Halasa
me
mentioned that.
saying that, because there's an articles being published for oxytocin help to get rid from the visceral fat, and because it's
really?
a peptide like insulin, so something we can consider injecting it around the umbilical, just 2 international unit, which is less than 10% of what the woman takes when she's trying to deliver a baby. So it's kind of non-toxic dose.
And in-
Was there a study regarding that? Because if we say that it just reduces the visceral fat when you inject in a certain way, was there any linear study that showed that okay, you use 2 units, but for how long and what period of time, and they have done something before we can just say that go ahead and go and use it. One has to be very careful about. I mean, there are not too many side effects of it, but at the same time, one has to be very cognizant of the fact that there is a problem with that too.
Yeah, I agree with you, Dr. Patel, because you and others are frontiers, and most of the time the frontiers, they're the one who's gonna be moving forward and be the first. We know from the premises of oxytocin helps in dissolving visceral fat. And based on that, we can make our judgment that we can do it because it's safe. It's a drug that's less toxic, and injecting subcutaneous of oxytocin, it's already there. It's already been injected. So you're not the first in that terms. But just combining all these articles together, and that's where us as a frontier to start trying it and see if it works. I'm not saying that to do it to your patients. I'm saying it to do it first on yourself as a doctor, because that's what we do here, right? We're trying to be the frontier.
IGF-1?
What is that?
Have you read that about IGF-1 reducing the visceral fat?
Are you talking about
IGF-1?
The growth factor?
Yeah, growth hormone. When it is being utilized, it gets into IGF-1, and that's the
well, if you try it and it works, why not? I mean, anything you think it has some publications and narrative and premises, and there's no toxicity at all, like amloxanox. Just let's try it and see.
Yeah, I think it would be a good idea to sorry, I can hear myself. To try something like that, because eventually, people are not going to be taking semaglutide, and they're going to want to transition into something else. But I've tried the oxytocin on myself and the injections, and I didn't really notice a lot of difference. I'm almost wondering if some sort of liposomal concoction is the better way, because I did give myself an IV push with the oxytocin loaded in nanoparticles, and now that, I mean, that was the first time I really felt oxytocin. In fact, most of the feeling was neurological, because I felt like my neurochemicals were replenished. Like I hadn't felt certain the amount of dopamine release that I perceived was a lot higher than I felt in the 2 to 3 years, but it felt more like the way I've felt before COVID. Okay, if that makes sense. The other thing I know is that, but it was also short-lived, and it also triggered, I could tell it triggered autophagy, because my metabolism did speed up. I felt really hungry, but in a good way. And I had a lot of energy, and my brain was functioning really well. I wasn't fishing for words the way that sometimes I need to. And the other thing is, I've also seen the liposomal cream of oxytocin, and I don't know if maybe that would be something to, I'll definitely look into it, but maybe that's something we can create that might,
Dr. Joseph,
be a better way.
If you were looking for energy, I think that I have found one of the best molecule. That one is MATC, and that one you can really bring patients up within 3 days. Daily injection, and within third day. First day they'll notice some, second day, but third day they will, as if like that the 100-watt bulb is on. They feel that good. So that is something. If you are looking something for the energy and concentration, you may want to use that.
I've tried it. In fact, I like it very much. I noticed it a little bit more for again, it produced hunger in a good way. You know, I could tell my metabolism was sped up, and although I didn't really feel energy like neurologically, like my brain didn't feel like, you know, like wow, you know, I really feel like my best self, you
No,
know.
it will be like at an incline. It will not be a 90-degree response. It will be more like a 45-degree response, and it does reduce the insulin, and it does have an effect on the hunger. I mean, you say that you had probably a hormetic response if your hunger improved, but our patients, those who don't have energy and they are heavy, so many times we have used this, and it has helped them and reduced their insulin, increased their energy, increased their fatigue, and so is their cholesterol.
Yeah, no, I really do like it. I think we may need to make a fine distinction when we say energy. Are we talking about body
Physical energy. I'm
performance
talking about
or
physical energy.
physical energy? Okay, yeah, because I was going to say that would seem more reasonable, because the brain energy has been the biggest challenge for me. But it's you know, I've had successes, but it's like I said, I wish we could maybe get the oxytocin, maybe even the nasal spray in a liposomal version, if it's possible, because I think there would be better absorption. Because like
Hey,
I said,
Dr.
when I
Joseph,
gave it,
let me ask you if I could please, what daily dosage of the nasal spray are you using?
well, I'm using it. Sometimes I'm doing 2 squirts twice a day. I'm doing up to the maximum dose. It's sometimes 48 units, sometimes up to, you know, close to 100 units a day.
Okay, I think 100 units
And it's
is
just
about where it works.
Yeah, well, you know, but I'm just saying, I don't know if a liposomal version would, put it like this. Some patients, they don't really notice anything, okay? And some patients do. And so it makes me wonder, especially when I did it IV push. Obviously, I know that's going to be a lot stronger, but that I mean, that was like obvious to me what oxytocin can do. Okay, it penetrated deep into my brain. I could tell, and it was like, wow, I feel like myself for the first time, you know, literally. And
what I
just
think
no,
it does when you give it an injection. When you give an injection, it actually induces your pituitary gland to release more oxytocin, but it doesn't really cross the blood-brain barrier from the body back to the brain much. It's 10 lanes out of the brain.
Well, wait a minute. Wait a minute. I had it in nanoparticle. I had it loaded in platelet-derived nanoparticles.
That's different, isn't it? Yeah. Okay.
Cool. I don't feel oxytocin injected naked subcutaneously. I never feel anything from that, and it makes me wonder how far does it travel.
Yeah, I agree with that. Dr. Joseph. I used that after Dr. Halasha told, and the first thing, it was very painful, and the second thing is that it just didn't do much. But then I thought, because it was painful, I didn't try it again.
Yeah. Well, this is awesome. Hey, we're having a great conversation on oxytocin here, but out of respect for Stefan, can we steer it back to his presentation for now, and then we can pick this up later? I think we're having a great discussion, and I think what you're talking about, Dr. Joseph, is what is the right dosage to get oxytocin to work like we want it to, and how can we best achieve that? And that's a great question.
Or what is the right concoction? Because if there is a liposomal form that would absorb more intranasally, that I'm just bringing up the question for discussion. That's all, to see if that's a possibility or what people think.
Have some evidence that it worked. You know what I mean? Like when you did it yourself, you actually tried it both ways, and found with the lipo or nano, it worked better. So absolutely. All right. Well, anyway, I just wanted to make sure we were respectful of Stefan's time just at this point, because we did deviate for quite a while from this presentation.
No, that's what this is about. We talk about different ideas, different things.
Okay. I just
Reporting
didn't want to
upward.
offend Stefan and run off one of our good presenters here. So, all right. Well, anyway, okay. Well, anyway, let's finish up. We can certainly. I love the conversation. Please don't think that. I just want to make sure that we're being courteous to our presenter.
Dr. Lewis, you had something?
thank you.
I was talking to myself here, and I was very effective. I agreed 100%. Then I figured out I was muted. But what I'm seeing post COVID is low white blood cell counts prolifically, even in those that are unvaxxed, and what I consider chronic mono. So we get Epstein-Barr, and most doctors will say, you had mono, when you were a kid, and that's why the antibodies are. But I've been doing the David Bronstein protocol. I forget who really put it together, but we call it, named it after him, with a high dose
Iodine.
AED and iodine, 4-day pulse, crazy high dose. And my best example is someone I can test on a regular basis. My daughter, really bad energy. She's on TV. She'd go for filming for a week, come home and stay in bed for 3 days. Now she's playing hockey, all kinds of things. But see, I've been following her Epstein-Barr, and she's done the protocol about 6 times. And it's come down from greater than 600 IgG down another step, and now down another step. And so there's a very clear correlation between the treatment and the Epstein-Barr antibody titers and the consequential improvement in energy.
Oh, fantastic.
Have you
And
tried
what you said,
Blue with
you said
Epstein-Barr?
Oh yeah. We've been doing.
Medlin Blue will be the best thing because it will attract to those viruses, and especially when you put them in the bed red light. I think Dr. Patel is doing it a lot. It may help to clear those viruses. There's a lot of publication on that.
What I do with people that are refractory is we'll do methylene blue, we'll do a baseline of ivermectin hydroxychloroquine, and then we'll do the 4-day pulse, Brownstein pulse, every 3 weeks. And that seems to be the most effective, putting all 3 of them together.
Iodine's great. I have all my patients get a Lugol's iodine. They all take it.
Something's iodine.
Yeah, where do we get the iodine?
Amazon.com.
Amazon?
I use iThyroid, 12.5 milligrams, and I'll have people do either 2, 3, or 4, depending on their tolerance. And I don't like, Dr. Carter on my team has done a lot of testing of high dose iodine long term, and he find it doesn't really. After a while, they get intolerant.
There's iodine, too much of it can cause hypothyroidism, damage.
Yeah, that's why I like the pulsing. The pulsing makes a lot of sense to me. We do a pulsing of the antibiotics for things like chlamydia pneumoniae. Another one, I know this is not about asthma, but Wellmore Webley is not someone that is a common name, but he's at UMass. And he shows that refractory asthma is actually a chlamydia pneumoniae infection. Very interesting guy.
Oh.
Yeah, he's been on my webinar, and I have that somewhere in the archives. But so they have the mucus. They have, so what's the cause of it? We got to look at that. And I've been successful at raising peak volume and lung volume in COPD with minocycline and methylene blue, Dr. Halassa, and methylene blue.
Good. The KPV you mentioned in the chat, I had success story today. I followed up with a patient. She had chronic Crohn's. She's only 35, but they've removed a lot of her gut. She doesn't even have a rectum anymore. She's been on Entevia infusions for years. It made her feel terrible. But I put her on a protocol, oral BPC 157, oral KPV for 1 month. And she feels great. And she might get a little bit of bloating sometimes, but she'll take it, pulse it, and it goes away. She hasn't had Entevia infusion in 20 weeks now. No flares, feels great. She feels like her life is coming back.
Yeah, I have a middle daughter that's has some sort of gut prolapse. And of course, in her world, I'm a quack, but I'm trying to get her to take this peptide, but I haven't convinced her of it yet.
Does anyone have a protocol for hepatitis B that seems to show promise?
I would look into thymosin alpha 1.
Okay.
Yeah.
How many times have you used it?
I've used it extensively for long COVID and viral infections, mononucleosis, EBV. You do 1.5 milligrams sub-Q every 3 days. It also works fantastically for allergies, really severe allergies.
Well, they
1.5
actually had the
milligrams
studies on it.
every other day or every third day?
Every third day, 1.5 milligrams.
Can you put that in the chat, Stefan?
Yeah, sure.
Yeah, thank you.
Yeah, you're talking about the
Yeah, I'll consider
then?
I'll consider the same thing, Methylene Blue and KPV, because KPV peptide for both, for virus, from fungus, for infection, because they make holes in those infected cells with viruses and they blow them up. So KPV is safe to do, and Methylene Blue, along with some red light and ozone for any viral infection.
Yeah, the TA1 has been studied in hepatitis, AIDS, Lyme disease.
Yeah, thymosin alpha, because it polarizes the immune system to Th1, and that's what you need to kill infected cells with viruses. You need to make sure you have a lot of cytotoxic T cells. So thymosin alpha, Methylene Blue, KPV, I think those are drugs that may help to get rid from those infected cells with Epstein-Barr virus or all those enveloped viruses that we call them.
Yeah, I have this one guy, he's a landscaper and he has such severe allergies. And he gets the crew mows the lawn. He'll be down for like 2 weeks, like bad, can't breathe, feels terrible. But he does now thymosin alpha 1, like just on the weeks where he has to go and mow the lawn with the crew. And he recovers in a day, where previously he'd be down for like 2 weeks.
Let me make explanation for this, because all the allergies people, they have Th2 dominant. They have, their immune system is polarized to Th2, right? And that's why they have a lot of IgG and all that. So what you need to give drug that push things into Th1. So thymosin alpha push the immune from Th2 to Th1, along with interferon gamma as well. I think Dr. Patel is using interferon gamma because thymosin sometimes alpha is not available in New York. But it will be a replacement for interferon gamma, small dose you use. Yes, and again, Methylene Blue, ozone, and all that stuff. Amloxanox will be good for asthma people because it's a mast cell stabilizer and it's a bronchodilator as well. So something you want to add to the equation.
Yep.
Stefan, where can we find thymosin alpha these days? Because it disappeared when we needed it the most, as usual.
You can get it from here. It's called Prime Peptides. I give you my rep's contact info. What's her name?
Is this one of the places that is like for research only, or
No. It's nothing like that. It's for prescribers only. You have to have a license to order it from here. I'll put it in the group chat. You contact my rep, you tell her I sent you, and she'll hook you up with an account.
Yeah, no, that's fantastic, because thymosin alpha, I mean, that's one of the best ones. And yeah, and I remember there was a study with hepatitis, either B or C, and they did it for 6 months straight, I believe. And even at 12 months, many of the people had no evidence of infection.
How many milligram is it in that bottle?
Oh, let me see here. You can get it in 15 milligram. And if you get it in 15 milligram, it's only like $150. Shipping's a bit expensive. It's like $20, but overnight's like $60 in some states. So that's the only downside. It's the shipping.
Hey guys, talking about thymosin alpha and thymosin beta 1 or whatever it is, beta 2. I don't want to, and I'm not discouraging the use of this, but I just say be careful using it. The FDA did put out a thing telling compounding pharmacies you absolutely can't make these two drugs. So that doesn't mean somebody else isn't making it. But my caution is, I wouldn't post that anywhere or use that in any marketing or advertising, or if you use it in the treatment of a patient and that's between you and them, that's great. But I wouldn't put that anywhere on a website or any kind of opinion piece, publish an article talking about it, or associate yourself publicly with it. Even though they're great treatments, and it's very clear in the biochemistry why all these drugs this company has are fantastic. You can see that. And I don't sell any of these, so I don't think I have any horse in that race. But yeah, just be careful on that side because they specifically put out a bulletin about that subject.
Yeah, same with these tirzepatide and semaglutide. You got to be careful not to advertise either of those.
Mm-hmm.
How about his DAO by Zymogen? I hear it's their third top seller, and they have huge results with it. If you can.
Zymogen's different, I think. They're a big company. I think you're okay. But, yeah.
Have
This
you
one's
used
amazing. No, I never used that. Have you ever used Semaxillank intranasally?
Well, the combo I haven't tried before. I'm very interested in that.
Oh, it's amazing for your patient with the brain fog, the post-COVID vaccine injury, fatigue, brain fog. You give them this up the nose, they'll feel great.
Well, I can tell you. I can tell you that I did the C-Lank and the C-Max. That was one of the first ones I tried, and I'll be honest, I had limited effect. I mean, the C-Max, it was like, oh yeah, and then it kind of petered off. But the combination may be stronger. But yeah, there's levels to this brain fog thing. Just to let you know, there are some people who I call them the impossibles, and I know that because I'm one of them. So for some people, they may respond. That may be the magic, the C-Lank and the C-Max, because I do like these those kind of mechanisms.
This one, Dr. Joseph, I want you to do this one.
Yeah, no, I'm glad. So that's where to get it from.
Yeah.
Yeah, thank you, because I've been looking for that one for a long time. I tell you, when I needed them the most, they magically disappeared.
Yeah.
Stop using them.
Yeah, so cerebrolysin KPV, because I think Dr. Patel was looking for a peptide that's angiogenic, that stimulate the growth of blood vessels and stimulate the release of vascular endothelial growth factor. Cerebrolysin, KPV, and BBC 1.
You there? All right, we lost him.
See, I told you guys not to talk about it.
This one's great. If you want
They got him. He's done.
This is the way to go for growth hormone, CJC ipamorelin. It's fantastic.
Dr. Boehmer, that was a classic moment in nitro medicine.
Does anyone use this one, lorazepam? It's wild.
No, but I do use a CJC 1295.
Yeah.
The best way I can describe it is I used to say, what was I saying? What was I saying? I'd say that during sentences.
Oh,
and after I started injecting that, it just went away. It absolutely went away.
What is lorazepam?
They found it's a toxin is secreted by Vibrio cholera, but it can improve like the gap junction in leaky gut syndrome. I haven't used it much. I was wondering if any of you guys had.
But immunoglobulin does the great job. So
Immunoglobulin, like what? Colostrum?
Yeah, and that orthomolecular has a very good product called SBI Protect.
Yeah, I use colostrum all the time.
Yeah. So invariably, I can say that it works in 99% of the patients.
Does anyone use this one, LL37? Never used this one before.
Well, it makes sense, except for it might trigger inflammation in people with psoriasis.
Yeah.
Because it's one of those S100 proteins, but they're bactericidal. They punch holes in their membranes. They're just attracted electrostatically. It makes sense. It's like having an antibiotic without an antibiotic. And in fact, they're looking for those things in one of the articles because these are proteins that are produced by our immune system and possibly other cells that are, extra protection against bacteria and other pathogens. But when I understood it better, I realized it might trigger more inflammation in somebody with a history of psoriasis, because those people like myself, they have an increased production. They found them to have more of that circulating around, and it triggers Th17 polarization. But for acute cases, for the right person, I think it could be a great thing.
There's
I have used LL37. I used it on chronic fungal skin infections, and it helped faster than the topicals.
I have a girl who's struggling with that right now. We've tried everything.
Yeah, you can try that.
Yeah.
Have you tried this on yourself, Stefan? All these products here?
I've tried let me tell you the ones that I've tried. I've tried this one. I've used BPC plus thymosin beta 4 extensively for repairing various injuries in myself. And I've also used CJC ipamorelin quite extensively. Copper peptide as well, GHK copper. I've used this one. It stings when you inject it, but it's supposed to be very good for anti-aging purposes.
No side effects. Pretty. I mean, you vouch for this.
Well, I've never experienced any side effects in any of these, including myself and like the hundreds of patients I've used these on, with the exception of obviously semaglutide, and that one can make you kind of sick if you eat too much. Where's that?
Thank you.
Yeah, we've got to get another replacement or get away from semaglutide. I'm starting to have
I don't like it.
having like almost like small fiber neuropathy type symptoms, and it's kind of scary.
It is.
People that are losing muscle mass, and it's
good.
not. I knew there was
Ozempic. You mean Ozempic?
Yeah.
Yes.
We have a doctor here. It was here, and he talked about his wife, and he took that wife, and she ended up in ICU from pancreatitis. Ended up with type 1 diabetic, type 1. So I think Ozempic, it's going to be pulled out from the market because a lot of people are going to the ICU. But in case they are needing it, and especially for people with 300 pounds or 100 pounds of weight, then you just have to boost them with NAC and amloxanol, things that helps to decrease the inflammation and protect the pancreas. So as much as antioxidants, NAC, Loxinox, take care of the methylation if you able to optimize the health of the body before you give them Ozempic.
Yeah.
Because I think it's giving it by itself by monotherapy. It's a danger thing without being primed and co-administration with other things. It has to be in a multi-therapy regimen. I think there's even some people are patenting with NAC to reduce the toxicity. It's being patented. Somebody's smart guy happen in the future. They're gonna add things that helps to reduce toxicity, and one of it's the NAC. So that's the why NAC is a very good thing. I mean, for any drug, not just for Ozempic, for any drug, anybody has taking drugs, whether it's narcotics, steroids, whatever, just start prescribing NAC, and especially if you add the glycine at night, so you can have complete detox.
All my patients are on that and iodine. One I've used extensively as well is the epitalone. They don't say it here, but it's fantastic for restoring sleep, right? It makes their pineal gland secrete melatonin appropriately. Fantastic for people with difficulty with sleep.
No, and that's good. I'm curious what's working best for sleep for people, because I was really thinking about this and talking to somebody else, and it's true. Now that people are not necessarily sleeping as well as as they think they are, or they're sleeping a little bit, waking up, and that's a problem when we're battling chronic inflammation. You know, epitalin, I could speak to that. I had nice, good dreams with epitalin, but you don't use it. It's just a short-term thing.
You cycle
Delta wave sleep,
yes.
or DSIP or whatever you want to call it.
DSIP.
That one's, I mean, it makes sense. What's that?
This one's fantastic. We will use both.
Yeah, we need
the DSIP and the epitalin for sleep. Yeah. And then
yeah, we need it now. I didn't have.
This.
It doesn't knock you out. I can say that, but you know, the purpose is to get as much delta wave sleep, which is the stage of sleep right before the deeper sleep, but it's the stage where the lymphatic system, and that actually I was going to lecture on that one. It's the lymphatic system is how the brain detoxifies itself at night, and it can only do that in delta wave sleep. Yeah. And that's a huge thing. So if you don't detox your brain at night, well, what do you think is going to happen? You're gonna have brain fog.
Yeah.
You know, that would be a way to think about it. What else for sleep? Anything else?
So any growth hormone peptide, whether that's CJC, ipamorelin, or even MK677, although this one's kind of a double-edged sword, you'll make them eat a lot. It stimulates the ghrelin, so they get very hungry with this. So it's great for someone who can't gain weight, but don't give it to someone who's a diabetic. They eat too much. But CJC ipamorelin has less of that appetite effect. Fantastic for sleep, though.
Have you ever had any failures with semaglutide? I had a patient that did 2 vials already and still not getting any effect.
Yeah, I'm having a patient with that, and now we're switching to this one, tirzepatide. Yeah.
And that worked even with
Well,
that.
we're just trying it because this just came online here, and I didn't even know we had access to it because it's prohibitively expensive for the patient through commercial pharmacies.
Okay, thank you.
But
and anything else for sleep or say anxiety? You know, is there a good
progesterone
for
progesterone for women at least. I haven't tried it in men, but it'll work for sleep.
Dr. Clearfield uses
it.
I
know that.
Oh, really?
Yeah, he does.
Yeah, I know DHHB, which is a extract of. It's a bark. I keep forgetting what kind of bark. It's an old Eastern medicine remedy, but they have it at another pharmacy, at the Pure Pharmacy. I found that one to be good. It's like, especially for patients dealing with a lot of anxiety, you can pop them any time of day. They take the edge off of anxiety without sedation. But I did find that it did help with sleep. I haven't found the one peptide though, that is like the ultimate, sleep peptide. They all sort of help. And maybe that's all we should expect, but that's just where I'm at with how to optimize sleep.
It depends what you're deficient in.
Right?
So if you have the low testosterone, you do the testosterone. If the woman has low progesterone, do the progesterone. If they have a low growth hormone, they're going to respond fantastically to growth hormone or one of the peptides.
In the cancer center,
Benadryl is a very
use,
safe sleep-inducing agent.
Which one?
Benadryl. It's dirt cheap, and you can use it in low doses with melatonin and a little bit of magnesium gluconate. And it's not like taking an Ambien, but it's a heck of a lot better than just melatonin alone.
In the cancer center, we use a Rick Simpson oil.
Yeah.
So for cancer patients, it has a 2-to-1 ratio of THC to CBD. So just be careful at nighttime, because they can really go groggy and even have hallucinations. But we use it for anti-cancer effects and even increasing weight and appetite for them. Well, yeah, just be cautious about it.
Yeah.
You mean Benadryl?
I know Dr.
I
Quinn.
use Benadryl. I use the same Benadryl, 4 tablets and 1 glycine, 1 gram, and I sleep like a baby. I cannot sleep. Sometimes I have insomnia and I cannot sleep. And if I do this is my solution. So I don't know about other peptides, but as Dr. Klatz said, it's the cheapest thing to do. And it's good for cancer prevention, Benadryl, because it polarizes the immune system to Th1. So that's the beauty. So you are kind of two birds with one stone, especially at our age. The cancer is coming out. So I will use it, but not every night. Trying to get away from 1 or 2 nights, to put breaks there. According to, I think, Harvard research for cancer prevention, because it helps to polarize the immune system Th1. That's why we give it for post-COVID. We can give it for HIV people, and for many who need cytotoxic T cells and Th1 polarization.
I'm going to second what Melvin Nario was saying. A lot of the veterans have chronic insomnia like there's no tomorrow. It's a dream pin, and it's super indica with CBN, and it's at a ratio of 67% THC, CBO 0.17%, and total CBN is almost 21%. And you just do one little puff, and it's been helping with my insomnia quite a bit. And I second what Melvin was saying about Rick Simpson oil, and it increased my appetite tremendously. It was massively wild, and you don't really get the high effects, and you definitely don't wake up groggy.
How do you use the Rick Simpson oil?
Usually it's a little, they recommend like a half of a rice or a full rice. You start out slow, and I used to do it sublingual, and it's kind of tricky because you've got to wet your finger and then rub it in there and kind of push it on because it's a little tricky.
Yeah, in our patients, it's more of, it's more intrabuccal. So we rub it on the cheeks, side of the cheeks, so it can have a slow release. But majority of our patients does have hallucinogenic effects. So there now becomes an option of rectal suppositories. So we find a mold and we pour maybe even coconut oil and that 1 grain that Joel was talking about. We drop it in there and freeze it. So when the patient is ready to use that, we now unfreeze that and just thaw it out a little bit, and then it becomes a rectal suppository. And the side effects for the central nervous system is less with that approach.
Where do you order it from?
Here in Nevada, dispensaries carry it. So it really depends on the state. You just go into a dispensary and ask for Rick Simpson oil. Or we have patients who are just having a hard time getting the ratio. They can manually make the ratio of 2 to 1 instead.
Yeah, I know Dr. Quinn has a sleep concoction, and it's cannabis, but there's no THC, but it's got I guess it hits the CBD1 or the CB1, CB2. I'm not sure if I'm even saying that right, but he's somebody too. If you're looking, where to get that classification of a sleep aid, Dr. Quinn would be the person to reach for that. So I've tried it, and everything has its place. I mean, I use other things too, but sometimes I go right back to his product as well.
All right, guys, we got to call it a night because I have another lecture tomorrow with Dr. Clearfield, do an update on prostate community trial, be co-presenting with Dr. Kathleen Reddy. She's an interesting person. She's an OBGYN retired and has been using ivermectin to treat cancer, as I have, along with large prostates. So we'll be giving our reports on that, and then she's going to introduce a full-blown American clinical trial she wants to launch, and we're going to try to support her the best we can with that.
Thank you, Stefan. This is the best that there is in healthcare. I mean, getting a group of doctors who are experienced across the board, who have a wide area of knowledge together in one location where they can share their life experience. Amazing. It doesn't happen anywhere else in medical education, at least in my experience. So thank you for a great presentation tonight. I enjoyed it very much. And thank you everyone else for sharing your hard-won wisdom.
Great to have you all. Thanks.
Thank you, Dr. Klatz, for attending, and Dr. Stefan for presenting today. And hopefully we'll see you next week, Monday. I think Dr. Juice present platelet nanoparticle, right? Dr. Yusuf, are you ready for that?
Oh yeah. Oh yeah. Yep.
Wait,
I'll be ready to present that one.
exciting stuff. All right, see you guys.
All right. Thanks again.